We now move into session 19, the penultimate session for our conference, Sustainability, 6 Key Updates in NABH 6th edition, a session that brings together what truly defines the future of healthcare, not just what we deliver, but how responsibly we deliver it. Because sustainability today is not longer a parallel conversation. It sits right at the heart of quality, safety, and patient-centered care. To guide us through this important discussion, we have with us our moderator, Dr. P M Uthappa, Group Chief Medical Director at Narayana Health. Sir, thank you for joining us and leading this session. We also have an esteemed panel of speakers who will each bring a unique lens to sustainability in practice. Dr. Anup Warrier, speaking on Sepsis Bundle, Dr. Suviraj John on Venous Thromboembolism, Mrs. Gracie Matai on Patient and Family Advisory Committee, Dr. Sudhagar Singh on Patient-Reported Outcome Measures, and Mr. Saurav Sarkar presenting a quality improvement project on rethinking hospital meals to minimize food waste. A diverse set of perspectives all converging on one theme, how small, consistent shifts can create a lasting impact. With that, I invite our moderator, Dr. Uthappa, to take the session forward. Thank you.
Hello, good afternoon, everyone. I know this is the last session, so if you're all asleep, this is a good time to wake up. If you're feeling tired, that's okay. This session is about sustainability, and nothing tests sustainability like the last slot of a conference. So when we hear the word sustainability, we often think about green initiatives, we think about waste management, energy conservation, but it takes a broader and more meaningful view. Sustainability in healthcare is about sustaining outcomes, sustaining safety, sustaining patient engagement, and sustaining responsible use of resources. So this session is actually about how clinical quality initiatives drive sustainability. It reflects exactly that, from sepsis bundles to VTE prevention, from patient and family advisory committees to patient-reported outcome measures. And finally, a quality improvement project on food waste. Each topic shows how sustainability is embedded into everyday clinical practice. So these are not standalone initiatives. They represent a shift towards healthcare that is safer, smarter, more efficient, and truly patient-centered. So let's begin with Dr. Anup Warrier, Senior Consultant, Infectious Diseases and Chief of Medical Services, Aster Medcity, Kochi. He's going to talk about Sepsis Bundle. Thank you.
Can I have my slides, please? Good evening, all. So I'll give you a quick brief on the Sepsis Bundle and how it connects to the 6th edition NABH as a new clinical indicator. And it's connect to sustainability, already Dr. Uthappa has mentioned, and you can take home the message based on that. So first thing is that the Sepsis Bundle has evolved over the years, looking at multiple levels of evidence. Its various parameters have collected over the time. As you see, it started somewhere in 2016, and what we have today, the Sepsis Bundle as a part of 2026 Surviving Sepsis Guideline, is what we will all follow going forward until the next edition comes. So there were certain changes which have been a part of this 2026 update, and my job in next couple of minutes is to highlight what are these parameters which encompass the new Sepsis Bundle 2026, the Surviving Sepsis Guidelines, and how do you incorporate it into your NABH clinical indicator. So what is in star is what has been added, and what is otherwise was there always in the background. Screening has now moved into pre-hospital screening, so that is something new. So if they say that if the patient has been transported for more than an hour outside, in the ambulance itself, there should be a pre-hospital sepsis screening to identify patients at risk. And the first dose of antibiotic can be provided in the ambulance if those screens are positive. What screening tool should be used? Now the most validated tool is NEWS2 compared to QSOFA and SOFA, especially QSOFA, which was used as a rapid screening tool earlier. So that has been pushed into the background based on its specificity and sensitivity. And the only tool which has the best pickup in terms of identification sepsis is now the NEWS2. The newer sepsis guideline also go on to suggest that if you would have a code sepsis or something called as a sepsis huddle, that means somebody meets the NEWS2 standards, you have a multidisciplinary team who comes at the bedside and together makes the call on the further steps to be taken and the resuscitation standards. Something which should be done at the time of diagnosis or suspected diagnosis is drawing the blood culture before the antibiotic is administered and doing a blood lactate level. Okay? A blood lactate level is supposed to identify hypoperfusion of the organs earlier than gross, obvious hypotension sets in place. So it's supposed to be an early marker of progressing sepsis. So therefore, drawing a blood culture before administering the antibiotic and sending a blood lactate is something which you're supposed to do first. Followed by that, the next most evidence-backed recommendation is for your antibiotic timelines. So the antibiotic timelines are based upon whether the patient is in septic shock, actual shock, either be it lactate-wise hypoperfusion or with your physiological shock, or there is suspected sepsis but his physiology is maintained. 1 hour is for where the compensation has failed. That means either the patient is grossly hypoperfused with lactate or has a low blood pressures. So here, what you require is 1 year, that 1 hour. The target of giving the antibiotic is 1 hour. And for others, it's 3 hours. Why this 3 hours? From the stewardship perspective, it gives us enough time to evaluate and decide whether the patient needs broad spectrum antibiotic or with further diagnostic, like maybe an X-ray or an ultrasound, can I get a better provisional diagnosis and use narrow spectrum? So in a less severe patient, so this gives us an opportunity to use narrow spectrum antibiotic in sepsis. The third hour bundle is about the fluids. So by end of 3 hours, you are supposed to give a loading of 30 ml per kg of crystalloid. So there is no more ambiguity between crystalloids and colloids in the new guideline. It's crystalloid, so saline is fine, 30 ml per kg to achieve a mean arterial pressure of more than 65. And in elderly, they give a leeway and they say that keeping high MAPs are in fact detritus for elderly. So keep it between 60 to 65 instead of more than 65 in the elderly. Following this, there is a dynamic reassessment where you look at the perfusion and the achievement of physiological blood pressures with capillary refilling time, leg raising test, and serial lactate measurements. And these all are have to happen in the first 3 hours, and you are expected to reach a certain targets by the end of 6 hours. 2 things to be achieved at 6 hours. One, and both of those are new. Okay. So the source control is a very important addition. So we are expected to screen, identify, and perform source control where it is required, like an abscess which requires draining. And if the patient requires or is identified as sepsis, within 6 hours he is expected to be in the ICU. This is something which is again new. So this is the first time that a ICU admission target timeline has been set by the surviving sepsis guidelines. So this is my final slide, and this is how you would operationalize all what I have said. So we need for the NABH as a clinical indicator, we need a denominator. So which are the patients for whom you will check this bundle? You would need to evaluate or look at this bundle compliance for all those patients who meet the NEWS2 criteria with fever who enter your ED. Okay? So what is the screening tool which was recommended? NEWS2. Will all news to come in? You need to have fever to have some kind of a differentiation between sepsis cases and maybe a trauma case. Okay. These are the parameters listed. Blood cultures known before antibiotics, serum lactate, IV antibiotics, fluid bolus, MAP achievement, source control and admission. You can note the compliance as yes, no, or not applicable. Not applicable because sometimes source control would not be applicable, sometimes within 3 hours or 1 hour will not be applicable. And this would be your compliance for that patient. And this, based on this is how you calculate your bundle compliance for the sepsis. I have also put up that small table there just to highlight what is included in news 2. As you can see, it is all very common parameters that are captured at admission in the ED. Right? Respiratory rate, saturation, whether the patient is on supplemented oxygen, blood pressures, pulse, consciousness and temperature. So very easy screening tool, all captured at the both bedside by the time the patient gets admitted to the ED. So I will stop here now and I will hand over to the next speaker. Thank you.
Thank you, Dr. Anup Warrier. That was great. That's a great reminder that timely clinical protocols do not just save lives, they also help sustain critical care resources and improve outcomes. The Sepsis Bundle actually showcases clinical sustainability. So early intervention reduces ICU stay, reduces antibiotic overuse, reduces mortality and reduces cost. This improves sustainable utilization of critical care resources. Mind you, the topic is sustainability here, which is explicitly emphasized in NABH 6th edition under clinical protocols, antimicrobial stewardship, outcome-driven care. Now we move from early recognition of sepsis to prevention of another major cause of avoidable harm, venous thromboembolism. Prevention here is both a patient safety priority and a sustainability strategy. Dr. Suviraj John, Senior Consultant Laparoscopic and Robotic Surgeon, Ganga Ram Hospital, New Delhi.
Thank you, sir. Can I have the slides, please? Yes. Thank you very much. I have a dual task about addressing sustainability, but also addressing the larger Indian context. Go this here. How do I control the slide? Yeah. Can I just go? There also. Thank you. 8 o'clock tomorrow morning, most of us are going to be back at work, including me in my operation theater. And as surgeons, we are very, very situationally alert and aware about the risk terrain in front of us, especially mortality, especially one that happens to you without warning. The number one cause of preventable hospital mortality in India and globally is venous thromboembolism. Due to shortage of time, I can't go into the subject matter. We recently published this editorial a couple of months ago to highlight that the Indian evidence is unequivocal that venous thromboembolism is probably the top cause of mortality in India. And for those of you who are a little curious, 2013, there's a British Medical Journal publication mentioning that in low and medium income countries, VT is the number one cause for adverse events. Mortality-wise, in the 1,000 autopsy case, 12% of all adult medical deaths was caused by venous thromboembolism. And this is a survey. I'm giving you all Indian data. 70% of clinicians attending one of our conferences said they'd experienced mortality in venous thromboembolism. And if you go into the finer details, every category and domain of medical and surgical intervention, venous thromboembolism in India resembles that of the West now. And so this is a summary slide with the evidence, because this is largely about physician and healthcare provider recruitment in their psyche. So VT in India is pretty much as bad as it's there in the West. So this is a take-home slide. I put it up front. Prevention of illness and healthcare-associated venous thromboembolism is now a clinical, legal, and accreditation mandate with the Government of India advisory backing it, and thus also a top health patient safety initiative. So the evidence for that is at the bottom. You could take a photograph for that. So how do we go about controlling it or preventing it? 60% of the burden of VTE is hospital-related. Up to 70% is preventable. That's the bulk of disease. Sadly, globally, less than 50%. In India, less than 20% get any decent prophylaxis. We are now changing the metric. I think we are much better off since 2012. Please also remember, for those of you who don't get convinced otherwise, If not the books, the courts will change your opinion. Today, in 2017, there were 8 cases of pulmonary embolism, the rulings going up to the High Court. Today, there are about 16 cases with a massive shift in the environment, 400% increase in medical legal cases in the last 3 years, and more than half the adverse rulings, half the cases have been adversely ruled for the hospitals and doctors. So VT prophylaxis for many people is the #1 patient safety initiative. How do we go about doing it? You have the legal as well as the clinical mandate for it, multiple guidelines which are India specific. And we, since 2012, have argued it with the government and the WHO. And the then and the now health minister released the National Patient Safety Implementation Framework, giving you now almost a regulatory mandate, mentioning that VT surveillance and prevention is now the function of every healthcare institution. And the NABH backed it in 2020 with COP16E and now COP16D. It's also, since 2013, part of the JCI standards. Please, first thing, make sure every hospital, nursing home has its own printed, documented VT prevention protocol and policy. If you don't have one, contact us and we'll help you create one. The main objectives we have now, like the HICC, we've got a VTCC to prevent preventable harm, mortality and morbidity, and medical legal issues in hospitals. This is the essential care pathway or prevention pathway. First, rule out pre-existing venous thromboembolism. A tertiary hospital like ours, the bulk of disease comes to us is actually pre-existing. Almost 2/3 to 80% of our cases are pre-existing. Anything after 48 hours of admission is hospital-related. We prepare a clinical order set based on the risk assessment for bleeding and for thrombosis, and then we implement it. I'm not getting the details because of the lack of time. And finally, you have a clinical order set which has to get constructed within 1 hour of admission. Now we're going to launch the EMR format for that, and this has to be implemented by the doctors and the nurses. We now have VT prevention as a mandated, documented part of our surgical safety checklist. It's now in the 4th column, which is the preoperative checklist. Benchmarks for this, the metrics is you have to have a more than 95% compliance to assessment and implementation. We are aiming for 100%, but it's a work in progress. If you're starting today, it's going to take you about 2 to 3 years to get to about 80% compliance if you leave it alone. But you do EMR, you can get to it quickly. This is the bundle checklist. We have a complete team of VT control nurses who spend the better part of the day actually monitoring compliance. And then we have a dashboard which is available to us online and as well as by on-site inspections. We're now involving patients also in giving us data regarding coagulation and circulation, bleeding risk as well as thrombotic risk, and recruiting their involvement in the VT prevention control. It's not just COP16D, which is now your primary reference, but standards from other domains also actually are part of your accreditation, and greater recruitment of these will help you get to a better implementation. There are globally recognized benchmarks for key performance indicators, and you can use them. These are publicly available. And of course, please do your quality cycle. We're actively involved in creating awareness and also a kind of a toolkit to help every hospital in India implement this. Please remember, especially for coagulation, as it is for sepsis, risk is extremely individual. It is a multivariate analysis, so you have to do risk assessment. Please ensure institutional and department VT prevention protocol. I'll leave you with a slide. I'll repeat, the prevention of illness and healthcare-associated venous thromboembolism is now a clinical, legal, and accreditation mandate. Please ensure your hospital has a policy document for it from tomorrow. Thank you very much.
Thank you, Suviraj John. Fantastic, and you finished within time. Thank you for that. Preventing complications is perhaps the most powerful way of delivering sustainable healthcare. In India, every death is almost a cardiac arrest. You know, VT or thromboembolic phenomena are underreported and underdiagnosed. Every patient who gets admitted, medical, surgical, obstetrics, or pediatrics should have a VT risk assessment done, period. Okay. Thank you for that. I can see you've done some great work there. So VT prevention reduces readmissions, reduces length of stay, reduces ICU escalation reduces litigation. So this is a safety-driven sustainability. Remember again, we are talking about sustainability here. NABH 6th edition strengthens risk assessment requirements, prophylaxis protocols, measurable patient safety outcomes. So clinical outcomes are important, but sustainability also requires meaningful partnership with patients and families. The next talk focuses on patient and family advisory committees. Madam Gracie Mathai, Group Chief Quality and Governance, Baby Memorial Hospitals, Calicut. She's going to talk about patient and family advisory committee.
Warm good evening to each one of you. Now, finally we have come to a stage where patient have to be involved in the care of patient. We doctors, nurses and other healthcare professionals, we think once the patient has come to us, it is our responsibility to take care of him from the admission till discharge, and we consider the patient as a bed number. Now, no, that is being gone. We have to involve patient into patient care. Why? The healthcare is being shifting towards patient-centered care. Patients are not just the recipient of care, but they are the partners in the race of their care. And Patient Advisory Council is a structured way to include patient in their patient care. From where it begins. You will agree with me, in 2023, WHO has announced during the World Patient Safety Week, the theme is Patient for Patient Safety. Now, WHO have said in September 2023, NABH also brought the Patient for Patient Safety aspect in the 6th edition, which is being released from 2025 onwards. How many of you are from the accredited hospital? Can you raise your hands? I think good number of those who are sitting over here are from the accredited hospital. How many of you have started this Patient Advisory Council? Can I have the raising hand? Very few. Only very few, even though the WHO has very clearly said us to start from 2023. And the NABH also wanted all our accredited hospitals, since I found that all of you are from the accredited hospital, that to start Patient Advisory Council, but we are yet to start. But my dear people, now this is high time we have to start. Now we cannot go beyond, because now this is one of the accreditation requirement which mandatorily you have to do. Why this is very essential? There was a trust by the patient towards the hospital, towards the doctor, and towards the entire healthcare activities happening, because they were totally dependent on the hospital for their care. Gradually, by our own fault, I will not say anyone else's fault, our fault, from the top to the bottom of the organization, the trust is being going day by day. And today, I don't think any of our patients have total trust in the care what we give to them. So the trust is being gone. Why? Because n number of errors are happening, and like we have seen one discussion with that moot court type in the morning session. It is that exactly. Each one would like to ship the thing to someone else. and nobody is ready to take the brunt on them. So ultimately what has happened, the trust is being totally gone. And when the trust of the patient is being gone, and there are mushroomings of hospitals are coming, and there are marketing by various hospitals in an unethical way, what will happen? Patient into a hospital where really they are not getting the real care. We have to bring to an end this particular thing which is happening over there. Now, what is the answer for that is the patient engagement. Each one of you will agree with me, when a patient comes to you, they will remain with us maybe for a short period, maybe 1 day, 2 days, 3 or maximum 4 days. Remaining part of their care is being taken by their relatives at home or maybe someone else at home, not in the hospital. They cannot be in the hospital for a long period. So they have to be engaged. A severe patient where you want to give physiotherapy to the patient at home, you cannot keep the patient constantly or continuously in your hospital. You have to send them home, and the relatives or the patient or someone else will be giving them the required physiotherapy. So let us involve the patient into the care of the patient. Another most important thing involving is that each one of you have to think that every patient is a unique patient. You cannot compare, though the patient is having same diagnosis, you cannot compare this patient same. Each patient is a unique, so we have to involve them into their decision making process. Now, how to engage the patient? From the patient and family, we have to form a patient and family advisory council. So every hospital, this was NABH requirement also, and this was WHO requirement also. So let us have a patient advisory council in our organization. Now, what is this? It's a group of patient, families and caregivers. They collaborate with the patient healthcare provider. They provide feedback, suggestion and insight, and aim is to reduce harm and improve quality to the patient care. Each one of us want the same thing in our day-to-day practice, that our patient harm have to be reduced and the quality of the care what you give have to be increased. And why PAC is important? It improves patient satisfaction, enhance the quality of care delivery, support patient safety initiative, build a trust and transparency between the patient family and the hospital, and align with the accreditation standard. Finally, it aligns with the accreditation standard. That's now today the requirement. There are various ways we have to form. There are steps in forming this council. Number one, you have to form a core group. Then you have to form a subgroup. It is something wrongly written. You have to form a subgroup. Third, you recruit members for this council. Out of that, you identify a leader. Then you identify the patient representative. Develop a charter that how it is going to function, what is the scope of this committee, and what can be the part of the patient in this particular committee. And let us give training to our staff, training to the patient volunteers whom we have taken as part of their committee. Why I said training to the volunteers? Because they should not involve in our day-to-day care. They cannot involve the day-to-day care. They may not be able to replace a clinical privilege of a particular doctor who is treating that particular patient, but there are certain responsibility for them to highlight it. And launch the PAC. That's what very important what we have to do. Coming into, when you launch this particular PAC, you have to see that the representative from top management, representative from quality, representative from patient also will be there in this particular committee. And in my organization, we have started this committee in 2023 onwards. And in the September, during the patient safety week itself, we have inaugurated this particular committee. And the chairman of this committee was our director. Even till today, he is the director. Why? the director or the owner is being made as a chairman of this committee because he is the topmost authority who take decision, and if he chair the particular committee, you know that action can be taken. Very clearly the scope of patients' involvement, patient relatives involvement is being there. In our hospital, the members of this committee are he, the chairman, and the CEO is the member, the chief of medical services is the member, chief of administrative officer is also the member, and our customer relation manager, these are also the members. We have taken 3 patients. One is the patient himself, was an old patient with a GB syndrome, and another 2 patients were the relative of other patients, those who were admitted over here. With this, we started forming the committee that I said. We have inaugurated the committee in September 2023, and what has happened from September 2023 till now, we have conducted 10 core committee of this meeting. Various patient related, particularly the relatives point of view, patient safety aspect, what they have seen is being corrected, and ultimately we have seen the patient satisfaction is also being improved. When I say one most important thing, one of the suggestions which has been brought by this particular PSC committee is that, see, in our, where you do in the cardiology, when we do the test, the steps were there where the patient has to climb and lie down on the particular coach. Now what has happened? That steps did not have a side railing. So what was happened? Older people, even though that only 2 steps are there, older people could not climb up because of that. There was no railing. They asked us to put a railing, and we put the railing, and then we found that yes, much patients were comfortable in climbing that particular. So there are many such things are there. Moreover, this is not ending over here. It end and it continue till the patient go into their home. So it continue with the home care. So we are activating actually all the 3 main theme point of the CAHO program, that is touch, tech, as well as the trust. All those things have been involved. And most importantly, the patient satisfaction is being evaluated, and we found that satisfaction of 100% it is improved. Now whenever there is a tussle, you know that maybe sometimes when the care is not appropriate or something wrong happen, some complication occur, the relatives were angry or they started grouping. In that time also, these committee members have helped us in solving many of our problems. So we are not limiting this committee inside the hospital itself, but it is limiting to once they go outside, and there also it will be continuing. So I request each one of you to start this committee in your organization, which is very essential for fulfilling the NABH requirement as well as the WHO requirement, and the ultimate aim is that the patient satisfaction. Thank you so much.
Thank you very much, ma'am. When patients become partners, care becomes more sustainable, acceptable, and effective. This is social sustainability. As you mentioned, this improves trust, shared decision making, reduced complaints, and improved adherence. This aligns with the new NABH focus on patient partnership, co-design of care, patient engagement governance, and that is sustainable patient care for you. Now that you have treated the patient, done operations or procedures, and what has changed for the patient? How is the quality of the patient? Quality of life has changed for the patient, and that's where the PROM come in. We have Dr. Sudhagar Singh, a senior consultant, Sri Ramchandra Medical Center, Chennai, to talk about PROMs.
Can I have the slides? Anyway, good evening to one and all who are present till the fag end of this conference. I could remember my mentor saying that the best speakers are chosen to inaugurate a conference, and the excellent speakers are usually reserved to close the conference. With that, probably I start my small, my view on probes. What is probe? When did this concept of probe started? Meanwhile, can we have the slides? Yeah, fine. I think it does not come up here. That's anyway, fine, no issues. It's here, so right, okay, fine. Okay. So when did this concept of probe really started? Way back in 1940-50 itself, WHO clearly said that health is not just a mere absence of a disease, but health means functionally, psychologically, and physically being disease-free. So it is a holistic definition of health. Traditionally, we have been measuring the health outcomes in terms of clinical parameters, like a test reports or an imaging science would help us to say that your health care has brought out a particular result. But there is something more to this healthcare outcome. A patient's perspective of a healthcare outcome is something very, very important. The patient might have a different way of looking at his healthcare outcome. He may relate to his health-related functionality. He may relate to his emotional component. He may even relate to symptom elevation and the functional and psychological aspect of himself. So these all could be the aspect of the patients when he refers to a best clinical outcome. When a patient says that he still has pain in spite of his clinical parameters being normal, we are missing something. So it is important that we listen to the outcome based on the patient's perspective. That is where PROM comes into very handy to probably assess our clinical care to these patients. Let us move on. So, a PROM can be of two different types. A PROM, which I already told you the patient's perspective, if it is predominantly psychological and symptom-based feedback, it could be a generic one, like how did the pain come down, how is he feeling better, how is his sleep quality, how is his emotional upkeep, all the things probably can be categorized as a generic PROM. Whereas we have something called disease-specific PROM, where a particular disease is categorized and a specific questionnaire are designed, which are validated, which are probably the patient has to probably give a unbiased feedback, which with the clinician's non-intervention, these feedbacks are taken and disease-specific PROM are collected. It is probably a little easy to probably institute generic PROM, but it takes little time, energy, and probably a well planning to probably institute a generic or a disease-specific PROM. When we look at the domains of PROM, it can be quality of life, it can be an individual care or a community. When you look at the quality of life, it predominantly talks about the physical upcoming of the patient, like the health status, the functional status of the patient, the probably the pain, the symptom elevation, and this anxiety and this, the sleep, how better he could sleep and get along with this normal routine work is probably the quality of life. Whereas if you look at the individual care, it is more of an emotional component where these can lead on to some kind of a good communication back to the physician to create a shared clinical decision making to probably plan the further course of the clinical management. And this PROM also can help us to identify if there could be a support which is required for this individual at the home level. So these are some of the parameters which the probe looks at. The client practitioner's communication is improved, where there is a shared decision making that happens, and then monitoring, safeguarding, care planning, and provider comparison. You can provide the healthcare providers among one another, how the outcomes could be, and this can help us to improve the quality, and then probably you can integrate different services to make a mark in the outcome of the patient. And there are barriers. Probably you should have a well-planned and a properly validated questionnaire and the resources to implement PROM. And definitely it impacts your services, and a good and documented and collected data, if analyzed appropriately, can lead on to further improvement of the quality of your patient care. This is probably the last slide. So this PROM was probably initiated or probably discussed from the 5th edition, and I think from the 6th edition it has become a standard, and I think every accredited hospital has to have their PROM initiated. These are some of the generic and probably disease-specific PROM which we have initiated in our hospital. Some of the PROM questionnaires we have digitalized, which could be taken probably at the time of discharge or probably at 1 month or 6 months follow-up during their OP visit. So our patient-guest relation can help us to collect this data, or we can send a link to the patient where they can share their outcome measurables from their home. With that, I think I thank the organizers for giving me this opportunity. Thank you, one and all.
Thank you, Dr. Singh. What changed because of the care we provided, best expense PROM? It also represents outcome sustainability. The PROM, the shift to focus from volume to value-based care, process to outcomes, and they support long-term outcomes and meaningful recovery. Finally, we move to a practical quality improvement initiative that addresses environmental and operational sustainability to reduction of food waste. Mr. Saurav Sarkar from BM Birla Hospital, Kolkata.
Good afternoon, everyone. So we are for the long day, and we are eagerly waiting for the valedictory ceremony. So I will cut short my presentation. So talking about my presentation, plate-wise. Myself Saurav from BM Birla Heart Hospital. This project was selected winner in the non-clinical category at the 5th Qualtech Prize for Healthcare. And we've observed that food wastage in our hospital was approximately 137 kgs per day, which is amounting to 4,100 kgs in a month, with a cost implication of around 92,000 rupees. So coming to the introduction part, at BM Birla Heart Hospital, the F&B team plays a very pivotal role in supporting patients by different cares. We work closely with dietitians and clinical teams to ensure timely and accurate meal delivery. However, despite our best efforts, there are severe problems which we have observed. So during team discussions and observations, we found that food wastage was identified as the most critical issues due to its impact at cost, efficiency, and sustainability. So hospital food wastage refers to uneaten or unused food prepared or served. Studies show that up to 40% of foods in healthcare goes uneaten, which is a stark contrast where 9 million children die from hunger-related causes annually. Consequences of food wasting increases operational cost till ethical concerns. We have SMART goals for this project, where our objective is to reduce 30% of daily food wastage and curtailment of food waste costs by 50%, which is achievable, relevant, and time-bound. Our baseline analysis over 3 months showed that an average of 137 kgs of food was wasted daily, which could have fed around 92 people. This resulted in a monthly loss of approx 92,000 rupees, making the problem both economically and socially significant. We have analyzed the category of food wasted by using Pareto chart. and found that various food items, which includes soft rice, soft veg, dal, complex, was contributing from 60 to 80% of the food waste. As part of diagnosing the problem, we broke down food waste into 3 key categories to better understand where losses were occurring. They were avoidable waste, potentially avoidable waste, and unavoidable waste. These classifications helps us identify key opportunities to reduce waste and improve overall efficiency. To understand the issue in depth, we conducted a root cause analysis using the Ishikawa diagram or the fishbone diagram. The major contributing factors leading to food waste are unappealing meals and food choices, lack of allergy recording, insufficient awareness, training sessions, sensation of our staffs, and cold food services. We adopted the DMAIC framework. For this project, we began by defining the problem in June 2025, and the project was systematically carried through all phases until November 25. We identified major problems and established clear responsibilities and timelines to ensure accountability. Our intervention focused both on people and technology. We trained and sensitized our F&B staff on food management, and at the same time implemented the Paper to Pixel initiative, which is digitizing the diet module. We also introduced the infrastructure upgrades from steel food trolley to latest design hot food trolleys to ensure food is served fresh and hot. Additionally, we implemented portion control bowls and trays, customized meals, and attractive crockery and cutlery for our pediatric patients. To log the improvement, we conducted regular audits. We collected feedback from patients, provided continuous staff training and sensitization. To sustain improvements, we conducted area-wise food waste analysis and implement phase-by-phase targeted interventions based on our specific needs. This initiative delivered both tangible and intangible results. We observed the food waste, which was 154 kgs in the month of November, was culminated to a savings of 58,000 rupees. In spite of a lot of interventions done, the patient satisfaction score remains uncompromised. Rather, it increased from 92% to 96% during our project timeline. Plate-wise demonstrate how thoughtful interventions can transform challenges into impactful solutions. While not all outcomes are tangible, the initiative delivers significant intangible benefits. Here are some of the positive feedback highlights from our patients. To mention, these sustainability efforts also contributed to our certification as an Eat Right campus from FSSI. Through this project, we welcome all of you to our journey on sustainability by reducing food waste, because leftovers could be someone's meal today. So let's all make a difference. We took help of Kim Problem Solving Pro to frame this project. We are especially proud that this initiative began as a grassroots suggestion raised by our kitchen utility staffs and fully supported by our management. Mention not a heartfelt thank you to our project team and a special note of gratitude to our regional head, Mr. Supratik Desarkar, for his continuous support and encouragement in making this project a success. Thank you so much.
Thank you, Sarosaka. This one is most obvious. Reduce food waste, reduce cost, reduce carbon footprint, and improve nutrition. NABH 6th edition newly emphasizes on resource stewardship, waste reduction, green hospital thinking, and this is operational sustainability. Mind you, we're still talking about sustainability. So we have heard 5 different perspectives today, but all converge to one idea. Sustainability in healthcare is not a separate vertical. It's embedded in safe care, prevention of harm, patient partnership, outcome measurement, and responsible use of resources. The NABH 6th edition reflects this shift from process-driven compliance to outcome-driven sustainability. So if we implement these ideas consistently, sustainability will not remain a concept. It will become a part of everyday clinical practice. Would request a round of applause to our speakers, please. In view of paucity of time, I'm going to not take any questions. Thank you all to the speakers and to the audience for engaging for this session. Thank you.